So, welcome back, everybody. I know you will have enjoyed this quite extraordinary film of a brilliant and such an impactful life of Dr. May Cohen. We have about 30 minutes for questions and answers. Our panelists are May, Barbara, and Cheryl. They're all ready to go. And please, if you could, type your questions into the question and answer box at the bottom of the Zoom screen. And I will read the question out and direct it to the person it's directed to. I would also ask you if you wouldn't mind letting us know who you are when you ask the question. I have actually received a couple of questions at the beginning of the session, so I'll maybe start with one or two of those and to give people time to get their questions into the Q&A box. The first question, not surprisingly, May, is directed to you. And it asks, in the film, you mentioned the importance of advocacy in the medical profession. In your experience, does our current approach to medical education and training adequately prepare young physicians for their role as an advocate when it comes to issues of public health and well-being? And if we're not doing that, what do we have to do to get that done better?
Well, first of all, you're in a better position to answer that question than I am, because I'm no longer associated with the faculty, being long retired. However, I believe that there is certainly more activism among students now and more social consciousness than it used to be. Whether that's part of the actual curriculum or sort of extracurricular, I'm not sure. But I feel that in general, young people now have a much more positive attitude towards activism and recognition of the social determinants of health. I also feel that the curriculum must continue to press the knowledge about the social. I have long advocated for the fact that the curriculum should also include sociology and psychology, and not just the biology of the body.
Thank you, May. A second question that has come a little earlier, which I like very much actually, was again addressed to you, May. What was the biggest gendered surprise, good or bad, that you ever had in your career?
The greatest gender surprise?
Yes.
That's a very hard question to answer. I've had lots of surprises in terms of the people have come along and have accepted the ideas of gender as a determinant of health. But I can't really say that I've had the biggest surprise. I think I've learned as I've gone along, I've learned a great deal. And if that is a surprise, yes, it certainly was to some extent. But that's a hard question to answer as the biggest.
Okay, thank you. The next question is from Helen Dang, and it's actually directed to the three female physicians on the panel, so May, Barbara, and Cheryl. What challenges have you faced in medicine, but what did you enjoy in medicine despite these difficulties? Compared to the past, what do you think are the challenges for female physician medical students currently face?
Well, let either Cheryl or Barbara answer that first. Cheryl?
Well, that's also a very interesting question. I think that it's kind of like the surprise question. I faced many, many challenges in my career. I was an immigrant. I worked in rural British Columbia alone as a rural family physician with the support of my husband only. I worked in a rural setting with only male colleagues on Salt Spring Island. I worked as the first woman faculty member at the Herzl Family Practice Center in Montreal. And I was the first woman chair of a department at McMaster University. So I had a lot of firsts, and they were all challenging. They all came with all kinds of experiences that I couldn't explain. And those experiences, in hindsight, I feel were gender-related experiences of difficulties that I had to overcome. And I think that one of the best parts of my career was the fact that I did manage to break those glass ceilings and move ahead and express myself to the best of my ability. But it doesn't mean that I did it all the time and that I was always successful. It meant that it was an ongoing challenge as it is today.
Thank you, Cheryl. Barbara, May, anything to add?
My perspective is a little bit different. I think one of the challenges for me when I started as a young family doc with an early, not very well-defined interest in women's issues was trying to figure out how I could merge my interest in women's issues with what I was doing as a pretty traditional family doctor, and finding a way to do that. And also, as I listened to some of my women patients and some of the experiences and stories that they shared with me, and I really felt like there were things that I needed to understand about their lives that I hadn't learned about in medicine. And I had to find a way to mesh those disparate perspectives. And for me, part of it was finding like-minded physicians, both in London, but a lot of it was at larger gatherings of physicians, to find people that had similar perspectives and to see how we could move some of these agendas forward. And also working with other people in the community who were not physicians, but who had an interest in those kinds of things. So that was one of the big challenges for me all along, and it varied over time with my getting increased experience and also some increased credibility within medicine. And when I look back, I think there's still lots of things that we need to do, but I look back and I see some of the issues that we tried to talk about that were kind of invisible now have become much more mainstream. And that's a good thing. And that reflects the work that a whole lot of different people have done.
Thank you, Barbara.
I agree with many of the challenges that Barbara faced, but some of the other challenges began in medical school, being a big minority, only a large minority of only 10% of the class, and being considered not real candidates who were really going to become doctors because we're going to get married and have children. Then I faced this challenge of combining my career with the family, which was a very major challenge. And I had to deal with many of the issues around that, including the guilt of never having enough time for family. Then there was the challenge of entering into a practice and being a family doctor at a time when family physicians were really considered to be second-class doctors. Having interned at the General Hospital, Toronto General, I learned enough about how poorly family physicians were seen as competent physicians. And then when I came to McMaster, I faced the challenge of becoming a faculty member. I wasn't trained as a faculty academic. I hadn't had much exposure to academics, so that was a big challenge. And then there were the challenges of moving ahead in academic medicine and taking on leadership roles. Again, that was a challenge, and it was very important for me to be supported by many of my colleagues who helped me to accept the challenge. So those are some of the challenges, in addition to the ones in terms of dealing with gender, dealing with non-medical colleagues, forming a coalition to deal with the issues that we felt were important. So those are some of the challenges.
you, May. A question from Juliana Duarte. That is, what do you feel is the next step to address the current gender issues?
Is that directed to me?
Yes, yes.
Oh, well, the first thing is recognizing that there is a gender issue. And there's been some recent publications, both from the Ontario Medical Association and also from the CMA in conjunction with the Federation of Medical Women, showing that women physicians do not earn the equivalent remuneration as males do. And there's a lot of questions about why that happens, but there's being investigation into that. So that's one of the challenges. I think women still face the issues of discrimination and also the challenges that they're faced with in terms of household and family responsibilities, which are still, I think, disproportionately carried by women who are physicians. So I think there are also, it has been evidence presented of discrimination against women in hospitals and medicine. Another factor, I think, is I've often spoken about the need for hospitals to have 24-hour childcare to be realistic about what it's like to be a resident or an attending physician on a schedule of 9 to 5. So those are just some of the issues, I think.
Very good. Thank you, May. A question from Mary Valentich, was somebody I think you know, May.
Yes, from Calgary.
From Calgary, absolutely. And the question that Mary asks is that human sexuality has disappeared from the curriculum of U of Calgary. You hinted that maybe the same was true at McMaster. Why do you think this has happened? Is it just because the pioneers have left a very active scene?
I think that's partly it, but then the question would be, why are there no longer pioneers who are pushing for human sexuality in the curriculum? I think the standard excuse is, oh, the curriculum is so full, we don't really have any more space for it. But I think sexuality is still a bit of a taboo subject. And certainly when we were working at McMaster, myself and my husband, Jerry, working with the issues of sexuality in family medicine encounters and how to deal with that in an appropriate way. We had a lot of sessions with various students, but nobody followed up after we did. And certainly I know that in spite of the fact that we kept teaching residents how to include this into their encounters with patients, I personally have never in all my years been asked by any physician any questions dealing with sexuality. And I think that's pretty general. So I'm sorry, Mary, we were the pioneers, but this seems to have faded away.
Can I just say something there? I think that there's a transition that's taken place in the curriculum, and that is about diversity and the definition of gender. We did a presentation as part of a workshop with the medical students in the ProComp program at McMaster University. And we discovered that there was a great concern about the manner in which we talk about gender only in a binary sense, and that there is, from the medical students' point of view, there was a far greater issue around the issue of gender being much more inclusive. And I think that once we start talking about that, the issue of human sexuality will start to become much more mainstream and normalized. And it's not an easy conversation to have, but those conversations are definitely happening at the undergrad and resident level.
May, somebody that also knows you, Gwen Warren, has given a potential answer to the question about the biggest gender surprise that you ever had during your career. And the answer, according to Gwen, is that as early interns, we monitored sessions wherein a patient had developed quite a crush on May. This became quite a shock to you, apparently. So Gwen feels that's probably the biggest surprise she's certainly seen.
I'm surprised now.
A question about going forward, and it's actually addressed to all three of you. The concerns about what are your biggest worries about moving forward in gender equity, and what do you think we all should be doing to make sure that the momentum is not lost looking into the future?
When you speak about we, are you speaking about the medical establishment?
Yes, I think all of us in the medical establishment, physicians, absolutely, medical schools.
It won't be lost if it's included in the teaching and the discussions, because if you do not consider both the differences between sexes or multiple definitions of sex and gender, they're both very, very important in the consideration of disease and health. And in order to make sure that you don't lose the momentum, you have to ensure that the teaching and the discussions and the curriculum include this this combination of an understanding of the impact of both social, namely gender, and biological factors in any kind of situation.
I think to some extent there is a great need to normalize discussion about not only human sexuality, but issues relating to discrimination on the basis of gender and inability to meet the health needs of people because they are of a certain gender, and inability to meet the full potential of a physician because of gender issues. And having the discussion is a very challenging thing. And I think that there's a huge opportunity to open up that discussion, to talk about very difficult issues with colleagues. And I just somehow think the medical students are ahead of us in this. I think with Black Lives Matter and the concerns about gays and lesbians and transes within our medical school, there's a new conversation happening. And I think the curriculum has to listen to what they want and to make sure that the issue of women is not lost in those discussions, and that we understand that women hold up half of the sky.
Thank you, Cheryl. A question, the questioner didn't leave a name, but says that she is a second-year undergraduate student at McMaster and is asking the question around specialties where the imbalance between male and female trainees is still present, examples of orthopedics and anesthesia. Do you think there is more that residency programs can be doing to increase the number of women in certain specialties?
Yes, indeed. When I was still on the faculty at McMaster, we used to have gatherings of students where some of the specialists spoke, and the physician who was the head of the Department of Surgery really went out of his way to explain how he was making concessions to enable women to be residents in surgery. And I think that it is possible to do that by recognizing some of the biological and social needs of women and how the residency program recognizes these. Certainly, there are now more women in the so-called male-dominated specialties than there used to be. That includes orthopedics, cardiac surgery, and whereas still in the women-dominated specialties, as I call it, such as family medicine, pediatrics, and OBGYN, you still have a vast majority of women in residency and also in practice now. In general, though, the number of younger women approaching equality with younger men in medicine is increasing. It's very close now.
Another question from an anonymous questioner, and that is in relation to the fact that there's still very much a glass ceiling and gaping gender pay gap in medicine. But sometimes women sabotage each other rather than helping each other in this context. Have you ever encountered this? And if so, how did you deal with it?
Well, I personally have not encountered women putting me down. In fact, my greatest supporters and my greatest helpers were the women with whom I worked, both in the Gender Issues Committee, the Canadian Medical Association, in the Women's Health Office. So I can't say that my personal experience has been that women sabotage others. I think that it's an unfair myth that women tend to undercut women. I think men are just as bad at undercutting their rivals or any of people that they see leaping above them as women could be. So I think that's a personal characteristic, not just a gender characteristic.
I think also as we take all these issues seriously, then men and women of sort of goodwill and good judgment will want these things, will understand that about fairness and equity and how these things should be applied. And I think also there's lots of really good research now that's available to show women's the gender pay gap, the gap in leadership roles and all of that. And so I think people from both men and women can be working together. It's not just somebody's opinion that these things are a problem. We can work from facts together and deal with a problem and try and work through it.
Thank you, Barbara. May, there are several questioners who have been addressing kind of the same question. So I'm going to paraphrase it into one to answer perhaps 3 or 4 issues raised by people in the question box. And that is, and I know you touched on this in the film, but what is the best advice you can provide young women who are considering entering medical school?
First of all, I want to know that they are entering a profession, which I think is one of the best professions in the world. It gives you all kinds of opportunities to do all kinds of different things and still do a lot of good in the world, which is very self-satisfying that you are able to do that. So I think that's the first thing I would advise. The second thing I would advise them is to make sure that they have an adequate support system, whether it be a partner, a spouse, or a close circle of friends. You need help, you need support, because it's a very draining kind of a profession. Sometimes it's very hard on you. It's hard to see people being ill, people that you've cared about for a long time. It's hard to work long hours. So it's hard to do both family and profession. So it's very important to make sure that you have the kinds of supports that you reach out to us. And it's also important to have a commitment to what you want to do, to believe that what you're doing is really very, very important and very self-satisfying.
Any other comments, Cheryl, Barbara?
I would always encourage young, there's physicians often talk about all the challenges in doing the work that we do. But the reality is there's so many wonderful aspects of being a physician, and every person can find a way of being a doctor that fits with who they are. But it gives you an opportunity to work with people and in ways that very few other professions allow you to get as close in very important times in people's lives and be able to provide them with some guidance or assistance. And that's just wonderful, despite all the political challenging things.
I just want to add one thing. There is nothing as exciting as delivering a new baby. I must tell you, when I did that, I used to drive home at 80 miles an hour because I was so excited.
I think that the one message that I would give to young people is to live a full life and experience all aspects of life and be open to what life offers you. It's really, really important to be able to do what you hope you can do and to achieve what you hope you can achieve. And that requires a great deal of work and many challenges. And if you want to balance family as well as your career, it's possible to do that, as we can see with May. And as we can see with both Barb and I, we all had families and we all had careers. And I would say getting into medical school is the biggest challenge. After that, the world is an oyster for you.
We have time for one final question. And again, this could be addressed to any of the three panelists. It comes from Susan Watt, and she asks, the question is, the reward structures of both clinical and academic medicine are dominated by male values and reward systems. Are there models which reinforce women's values and reward systems that could have been or could be infused into the system to encourage more and more effective participation?
What values can we inject? Well, I think some of the values that we've already spoken of are important. The values are commitment to your profession, a belief in what you're doing, a belief in the need to advocate for improvement in society, the need to respect all the people that you come in contact with, to respect your patients. Those are the values that I think are very important. I'm probably missing some, but I think that what we've talked about today in terms of understanding gender, understanding individual differences, understanding gender, those are all part of the values of being a person who respects the other person. And I think those are the values that we have to demonstrate in medical school. When we hear stories of supervisors who are not respectful to their learners, they are not injecting the values of respect. I think these are important issues.
Barbara, Cheryl, anything else to add?
Well, I would just say that the article in the CMAJ that just came out about the pay gap between men and women touches on all of those issues. The work that the OMA is presently doing to really, in a very ambitious way, try and address these very challenging issues, touches on these issues. And I just think that we're moving into a new era where women in medicine are not only in the younger age groups, but more and more women are growing through medicine and are influencing medicine about values that are more social than medical, and bringing those values into the everyday curriculum. And I have a lot of hope and a lot of faith in that. I also think that men are beginning to take on these issues. I think it's really important that men see this film, that men are engaged in the discussion, that men participate in some way. We've been surprised how few men have participated, have joined, have watched, and have contributed to the Q&A. And I think they have a lot to contribute. I think it's the men that are going to make this happen for us or prevent this from happening if we're in an equitable society. So that's where a lot of the work has to happen.
So I think we need to end. It's 8:30, and I want to finish this by thanking May for joining this evening, for making this discussion so memorable. But also, May, I don't get a chance to say this very often, for all that you've done for us here at McMaster over these many years. I've spent my entire career here, and the impact you've had in this place is just profound and lasting, but also for Canada and for the world. You are absolutely a treasure, and we all greatly appreciate the opportunity to know you and have worked with you. And to Cheryl and Barbara, brilliant film, absolutely brilliant. Thank you for the energy and commitment that went into making it. And to all of the people who attended, thank you for joining. It was a wonderful evening, and I hope you enjoy the rest of this evening. Take care.
Thank you very much, Paul.
Thank you.
Thank you all of the people who submitted very interesting questions to us.